Ladies and gentlemen, welcome to MedSynapse podcast series. Today, we have the privilege of hosting Dr. Rutendo Rukarwa, a consultant specialist physician and rheumatologist at Princess Marina Hospital in Gaborone, Botswana. With a wealth of clinical expertise spanning in general internal medicine, joint and muscle disorders, autoimmune diseases, and connective tissue disorders, Dr. Rutendo brings a deep understanding of the complexities of healthcare. Today, our focus is on the vital topic of rheumatoid arthritis, where we will be focusing on recognizing, managing, and preventing rheumatoid arthritis. Welcome, Dr. Rutendo.
Thank you very much for having me.
Thank you so much for joining us on our MedSynapse podcast. Let's begin the show. Dr. Rutendo, to begin with, understanding the nature of flares is very important. Could you please explain what defines a rheumatoid arthritis flare and how it typically manifests?
Okay, so with rheumatoid arthritis, first of all, it's a systemic disease. And because of the nature of the disease, it affects every single system in the body to those affected by it. And when it comes to the concept of rheumatoid arthritis flares, it becomes very blurred and difficult because the complexities are multifaceted in the manifestations of the rheumatoid arthritis. Therefore, you've got subjective and objective domains that determine your disease activity. So typically, a flare is described as a transient worsening in the severity of a disease or a condition, which will eventually subside or lessen with time. With rheumatoid arthritis, the flares are typically defined as an increased or an enhancement in your joint pains, increased in joint swelling, worsening of your early morning stiffness, and elevation of your acute phase reactants, such as your CRP and your ESR. And this can typically last for a day or two, but sometimes it may persist in some patients for weeks and even up to months. And how patients perceive their disease flares is very different, where you get some patients only presenting maybe with constitutional symptoms where they complain about severe fatigue, fevers, loss of weight, loss of appetite, generally feeling very unwell with associated night sweats. And it can even affect the mood of the patient, where they become more depressed with limited joint function and activity, and this can then affect their activities of daily living. So the concept of a flare, it's very diverse, and sometimes it becomes very difficult to define because of the variability and how patients perceive them from a patient to patient experience. Yeah.
Distinguishing between fluctuations and flares is very important. Could you please elaborate on how doctors can differentiate between regular symptom fluctuations and rheumatoid arthritis flare?
Great question. So the landmark trial that was done in 2009 for the outcome measures of rheumatoid clinical trial, the OMERATE trial, the group defined a rheumatoid arthritis flare as a cluster of symptoms, like I mentioned above, that are sufficient in duration as well as intensity and cannot be self-managed by the patient. So a patient may have tried this and that to try and make the symptoms better. And then this now requires initiation of therapy or a change in therapy or an increase in therapy. So I think this way it's a bit easier to define and differentiate between a flare versus fluctuations in disease. So regular fluctuations in symptoms are very common in patients with rheumatoid arthritis. However, most of the time the patients are able to manage this and without needing to see the doctor. Or any change in their medications. So they may wake up one day more stiff than the other. They may wake up one day with one joint that's acutely painful, but then it gets better in a day or two. So these are the typical flares that the patient will experience, the typical fluctuations. However, once a flare, by definition, when you now need to seek a doctor's attention, and they maybe need to change, initiate, or accelerate therapy. So being the nature of rheumatoid arthritis in that there's frequent fluctuations, they are objective disease activity and subjective disease perceptions that the patients may have. And the more experienced a patient is, the more likely they are to identify these fluctuations and deal with them. And you find that patients who are newly diagnosed, who have not really figured out these fluctuations, may actually present more commonly to the doctor complaining about these fluctuations, which can be managed by the patient. So basically, all in all, to say a flare would require the attention of a doctor and may need change in therapy versus the fluctuations that usually a patient is able to self-manage once they're educated and once they are more familiar with their disease per se.
Thank you so much, Dr. Rutendo, for simplifying on how we can differentiate between regular symptom fluctuations and rheumatoid arthritis flares. Now, moving on, are there specific biomarkers or diagnostic tools that help in identifying flares objectively?
Yeah, so like we said, though they're difficult to define a flare, there are certain tools that we can use that can actually objectively, as well as subjectively, define a flare. So, in terms of biomarkers, the most commonly used are your acute phase reactants, where a patient may present with an elevation of the CRP, C-reactive protein, or an elevation of your ESR. However, one needs to be able and cognizant of the fact that these are non-specific and you may have elevations due to other things such as infections or other things that are maybe happening in your patients. For example, in our setting in sub-Saharan Africa, with a high prevalence of HIV, you find that patients with HIV tend to have an elevated ESR, and that way it may be difficult to use an ESR as a biomarker for disease activity. So the other, and in terms of clinical disease activity indices, usually, there is your clinical disease activity index that's called the CDI, where you look at your total swollen joint count, your total tender joint count. Then you've got your physician global assessment on a visual, as well as your patient global assessment on a visual analog score. So when you add these and calculate, any score above 10 would make you think that the patient is undergoing a flare. More in terms of more specific, mostly used is your disease activity score, your DAS-28. Though it's difficult and usually you need to use a calculator, it's more objective because one can look at your change in your DAS-24 if it's greater than or equal to 1.2, or if your disease activity score 28 is greater than 3.2, you may consider that this patient is actually having a flare. So any changes in your DAS, your clinical disease activity index, even your simplified disease activity index can point towards a patient actually having a flare. So you count your joints, you count how many tender joints, how many swollen joints, but bearing in mind that there's a combination of subjective and objective things. So, for example, your patient global assessment may be very high in a patient who's, for example, got secondary fibromyalgia and may have increased tender joints and not that much subjective swollen joint count. So one has to also bear in mind what other comorbidities the patient has when you're calculating and trying to assess whether your patient actually has a true flare or there's something else going on. The other issue is that where is the patient starting from? So you've got a patient who probably has high or moderate disease activity. When there's a small change in their disease activity, which is considered a flare, the patient might not actually be aware of it because they're in a lot of pain, or there's a lot of tender joints and a lot of swollen joints. But a patient who's starting probably from low disease activity or remission, once they get a small change in their disease activity, it may be easier to pick up and quantify that. So it also depends on where exactly your patient is coming from. So those are the tools as well as the biomarkers that can be used to assess patients, and most of them having their advantages and limitations. So there is nothing really concrete that can be used. to do that. And then another objective way is to look at the duration of the flare and if there's any need to change therapy. So a 2 to 7 day flare sometimes may not warrant any change in your disease modifying anti-rheumatic drugs versus someone who has a 2 to 3 week or longer with no signs of improvement. Then there may be need to switch therapy and or modulate your therapy in your patient. So lots of shortcomings, but there are these things that the tools that you can use to try and really objectively identify a flare in a rheumatoid arthritis patient. Yes.
Managing flares is a key concern. How can doctors effectively manage rheumatoid arthritis flares once they occur?
Great question. Like I mentioned, because of the heterogeneity of how these patients present, it is very important for a doctor to be patient oriented. So basically, your doctors have to listen to the patients because there can be a discordance between the patient and the clinician identification of a flare, and more information needs to be obtained from the patient to try and resolve this discordancy. Because once you examine a patient and you find maybe there's not a lot of swollen joints, and however the patient tells you that they have a lot of constitutional symptoms or they have a lot of mood associated depression and anxiety, these things need to be put into place, or worsening early morning stiffness as possible flares happening in your patients. And so the key thing is to know your patient, be patient focused, and listen to your patients. So management obviously of these flares is going to be number one, to try and identify any triggers of the flare and ensure, number two, that your patient is taking their medications correctly, as well as inquire about side effects. We know that with these chronic diseases and the pill burden as well as the side effect profile, you find that most patients and some patients may actually not be taking their medications adequately or not at all because of the side effects they actually have. So before you actually say this patient is flaring, could it be an issue of adherence? So dig deeper into whether there are any side effects or any adherence issues, address any possible myths and misconceptions that your patient may have, and then also just find out your patient's understanding of the disease as a whole before you go on to increase and accelerate therapy without getting your patient on board. So in terms of management, basically I divide it into supportive or conservative measures and then specific. So, and this also depends on severity and clinical presentation. So, supportive measures include what patients can do at home that you need to educate them on. So, the use of hot or cold packs. This can increase your pain threshold and decrease the sensation of pain. So, normally you tell your patients that when they are most swollen, they can use a cold pack and not a hot pack because that may make it worse. But if the pain is worse with no swelling, they would rather use a cold pack. And usually they leave it on for 15 minutes at a time, and they can do this 2 to 3 times to 4 times per day. Other techniques they can use is to soothe the body and mind. So you're going to encourage a patient to undergo relaxation techniques such as warm baths, music, breathing exercises, going for a massage, anything that's going to just soothe the body and the mind can assist. Um, Another thing I always tell my patients is to call for backup. So encourage your patients to put into action a plan where they can have a family or friends help out during these flares. So in terms of not managing to do chores or work, they need to have a plan of who they can call and designate and schedule help during these flares. The other thing your patient needs is to have a balanced rest with activity. So you find some patients, once they're having flares or because of rheumatoid arthritis, they believe that they cannot and should not engage in physical activity. So during the flares, they should stick to a regular exercise program with alternate rest and light activity. So they may reduce their activity, but keep moving. That's what I tell my patients, keep moving. This should help with the disease flare as well. Some other things that your patients can use are supportive joint supports, so they can see the occupational therapist and physiotherapist who may prescribe splints as well as assistive devices such as crutches during the flares, so that you allow the joints and support the joints during the flare. And then typical use of analgesia, which can be over the counter or prescribed, such as NSAIDs, bearing in mind contraindications for your patients, as well as oral or topical analgesics that can be used by the patient. So these are some of the supportive, conservative things that patients can do. In terms of specific treatment for flares, if there's persistence and no improvement of the above, then you need to tell your patients to come and see the doctor and not to delay. So, with the treatment of rheumatoid arthritis, there is a treat to target approach where you aim for your patient to be in remission or low disease activity. And different things can be used when a patient presents, including use of intraarticular steroids. So, the large and small joints that can be injected should be injected during a flare if there's active synovitis. You can also use intramuscular steroids. So, let's say your patient has polyarthritis and you can't really inject 15 joints, you may opt to use intramuscular steroids. And also, the use of additional oral prednisone can be prescribed during these acute flares for a short duration at the lowest possible dose. And then finally, the doctors may consider a change in therapy. So let's say your patient was on conventional synthetic DMARDs. You may now need to escalate therapy to a biologic or biosimilars, or use of your targeted synthetics such as your JAK inhibitors, making sure you always assess your patient on a patient-to-patient basis in terms of contraindications, risk, and you discuss these things with your patient and ensure that your patient is on board with the management of the flares and the rheumatoid arthritis as a whole.
Dr. Rutendo, as you mentioned, exercise can also affect rheumatoid arthritis flares. Now, we would like to know, how does lifestyle factors like diet and exercise play a role in triggering or mitigating rheumatoid arthritis flares?
Great. Like most medical conditions, we know that lifestyle plays a pivotal role in terms of the pathogenesis of disease, management, improvement, risk factors. So, diet and exercise do have a part to play in helping to manage various rheumatoid arthritis, and as well as being potential triggers in the disease. So, in terms of exercising, it's encouraged that patients with rheumatoid arthritis engage in low impact aerobic exercises such as walking, biking, swimming, as well as also flexibilities, exercise activities such as stretching for 10 to 15. Most of them have stiff joints, so it encourages the patients to do stretches for 10 to 15 minutes a day. On top of that, strength training is encouraged where they now need to use weights and resistance exercise at least twice a week. And you also need to do balance exercises, if, for example, yoga or Tai Chi, which helps to improve the balance in these patients. So, regular exercise helps patients to sleep better, which is an advantage. They have more energy, and it all in all improves their daily function with less pain. And this is according to the American College of Rheumatology. Um, However, different modifications may be needed depending on your patient's level of fitness. So, a 60-year-old with rheumatoid arthritis versus a 20-year-old with rheumatoid arthritis, you wouldn't really prescribe the same exercise regime. So, one has to look at the fitness level and ability of a patient and then structure the exercises according to ability and as well as strength of the patient. Another good thing to use is water-based exercises. And then later on, this is mainly for patients during the acute phase or where disease activity is high because of a lot of pain. You may want to start off with water-based activities, or for your elderly patients for that matter, and then later on move on to your land-based activities. And for example, you can start off with chair yoga versus your classical yoga, and then you need to use pain as a guide. So exercise should not be painful. Once it becomes painful, then you know that the patient is doing something wrong. So exercise should not be painful. It's only supposed to give you them it should only just improve their disease. And not only that, it improves emotional moods of the patient, it lowers anxiety, and it promotes relaxation. So there are pluses of doing exercise, which you need to encourage in your patients. And above all, we know that with rheumatoid arthritis, there's a higher association with cardiovascular disease. So once your patient is active, that also reduces, and it's a plus, not just for the rheumatoid arthritis, but also the comorbidities associated with the disease. Okay, so then when it comes to diet, there are things that have been shown to be beneficial for patients with rheumatoid arthritis. There is no research per se which has been done. However, this has been the data has been obtained from case reports to say patients taking with rheumatoid arthritis, they need to be on a plant-based diet or a Mediterranean diet. So these have been shown to lower inflammation and therefore reduce disease activity in your patients with rheumatoid arthritis. So foods such as your fatty fish with omega-3, which helps with pain and early morning stiffness, fruit and vegetables, which are rich in antioxidants, will help to stabilize molecules and free radicals that trigger inflammation and damage. Whole grains, which may lower your CRP and reduce heart disease. Peas and beans have been a good source of protein needed for muscle growth, which is needed for these patients. Nuts, which are healthy with monosaturated fats. Olive oil instead of using other oils. Reduced sugar and limit alcohol. So all these things have been shown to be of benefit. Recently, there was a published randomized control trial, which is called the Plants for Joints, where they wanted to look at the effect of multidisciplinary team with lifestyle program in rheumatoid arthritis for patients with low to moderate disease activity. So the patients with the plant for joint group versus the placebo were followed up for 16 weeks, where they were put on a whole food plant-based diet as well as exercise regime and stress management. And it was found that these patients versus placebo, which is standard of care, did much better in terms of lower disease activity. They also had improved metabolic status, all in all, compared to the placebo. So food plays a very critical role, and it's something that ongoing research needs to go into. And then in terms of foods to avoid with rheumatoid arthritis, patients, I normally advise them to avoid red meat and dairy because these have high saturated fats, which can cause inflammation in fat tissue. Corn oil, sunflower oil, vegetable oils, which are a source of omega-6, which is not good for patients with inflammatory disease. They should avoid fried foods, fast foods, processed foods, because these are all sources of trans fats and they can trigger inflammation and also increase your cholesterol levels. And the other things are also specific, like low salt diet because of the high blood pressure and the high risk of cardiovascular disease, as well as onboard steroids and NSAIDs that we normally typically prescribe with these patients. So you'd want to optimize their blood pressure and encourage them to have a low salt diet. Alcohol does not mix well. Number one, most of these patients are on medications that can be hepatotoxic, such as your methotrexate. And if a patient has alcohol, you want a healthy liver. So you encourage your patients not to take alcohol. And the risk of peptic ulcer disease associated with alcohol, because these are patients on NSAIDs as well as ulcers, and you don't want to increase that risk. Fried and grilled foods have also been shown to be need to be avoided in these patients because when you cook meats with high temperature, it raises the level of advanced glycosylation end products in the blood, and this increases inflammation. So all in all, diet and food counseling has to be done for our patients, and it goes a long way in managing the disease, reducing flares, and overall well-being of the patients with rheumatoid arthritis.
Now let's move on to patient education. As we all know, patient education is very crucial. Dr. Rutendo, What are some effective educational approaches we can use for helping patients to understand, manage, and prevent rheumatoid arthritis flares?
So, I am a firm believer that an educated patient is a better patient, because once your patient understands their disease, because remember, when you see a patient, it's usually a consultation on average 30 minutes to an hour, and the patient leaves and spends most of their time at home with their family and on their own. And if a patient does not have a good understanding on the basics of their disease process, that is when the disease can affect the patient negatively, and there can be a lot of misconceptions and myths and things that the patients do wrong. So educating a patient on what, for example, in rheumatoid arthritis, what triggers the disease, what causes flares, is very important, so that they know what to avoid, what they can do, which foods are good, what sort of exercises can they do. And this helps the patient actually feel more empowered in terms of day-to-day management of their disease. Another thing is to teach your patients on how to use the conservative measures that we spoke about when it comes to managing flares and fluctuations in the disease, knowing what to do when the joints flare up, and without needing to see a doctor. So this is very important. Once a patient knows to say, when I wake up and I start having stiff joints worse than they were, what exactly can I do? I can start off by using a hot pack. If this doesn't work, can I go on to use analgesia? How is exercise going to assist me? What can I do? What can I not do? So educating your patient is important. Another thing is providing pamphlets as well as reading material or resources for your patients, so that when they go home, they can always refer and remind themselves on exactly what they can and should not do, and have a better understanding of the disease process. Support groups can also be very important once a patient doesn't feel isolated, because sometimes these diseases are very isolating, especially when your patient doesn't know anyone else suffering from their condition. So, support groups or having group sessions to allow them to share with peers and share ideas, I find it more helpful for the patient compared to what the doctors or the nurses say to the patient. What other patients suffering from the similar conditions say to the patient usually sticks better with them, and it helps them to have that support system from peers. Another thing is always to have a multidisciplinary team involved. You know, doctors need to work together with the physiotherapist, they need to work together with occupational therapists, they need to work together with dietitians, they need to work together with rheumatology nurses, as well as the family to get involved, especially for your elderly patients who need care. So that with a multidisciplinary team, you are better able to manage and prevent flares occurring in your patients. And another thing also is each visit to always ensure and check and reinforce adherence to therapy. Because, like I mentioned, with chronic diseases, most of these patients have a very high pill burden. They not only suffer from rheumatoid arthritis, most of them have other multiple morbidities. They have got hypertension, heart failure, strokes, they've got diabetes, metabolic syndrome, the works. So you find the pill burden is a lot, and you find some patients actually don't take their medication correctly, or some do not even adhere to the medication. So always with each visit, reinforce, check adherence, check side effects, and encourage the patients to take their medication. And finally, always co-manage comorbidities that are associated with rheumatoid arthritis. More importantly, fibromyalgia. You find that with unmanaged fibromyalgia, your patients have a lot more complaints in terms of joint tenderness, which is and less objective complaints like synovitis with joint swellings. So you need to be able to identify these comorbidities like fibromyalgia, identify depression and anxiety, and manage them accordingly. And this actually makes your patient present less frequently with flares or perceived flares, and better manage your patient holistically.
Lastly, are there any emerging treatments or research directions that might change how we approach rheumatoid arthritis flares in the future?
So definitely, medicine is never stagnant. We're always trying to learn. We're always trying to improve the management of patients, especially those with chronic debilitating diseases such as rheumatoid arthritis. But like I mentioned initially, because of the heterogeneity of defining a rheumatoid arthritis flare, uh, we need to probably go back to basic sciences to understand exactly how rheumatoid arthritis works on a physiological level. Before we can have a truly objective measure of rheumatoid arthritis flare, we need to truly have a measure of an objective measure of disease activity in rheumatoid arthritis. And like I mentioned, with the shortcomings of the various indices we use, like the CDI, the SDI, the DAS28, it's still an ongoing process in research with rheumatology to say objectively how can we define disease activity in rheumatoid arthritis. Uh, though our current matrices do assist on a practical day-to-day in decision making to say, okay, my patient has low or high disease activity, and that will inform me escalating therapy or changing therapy in the patient. However, there's still a significant we rely so much on the subjective measures, such as your physician and patient global assessment, and this makes it difficult to really have an objective definition of what is a disease, what is disease activity, and when is a patient flaring. So this is things that are still ongoing to try and improve in terms of defining a rheumatoid arthritis flare per se. Um, Also, there's been an investigation into looking at possible sensitive and specific biomarkers for rheumatoid arthritis, developing them and making them available, and these can be then used as tools to guide management of the patient. But all in all, more work is needed in the current time, especially within our because of COVID, with the increase in telemedicine, uh, it may be difficult for rheumatologists to be able to remotely assess flares as you're not actually physically seeing the patient. So more work is also going into that, where with increase in telemedicine, how can rheumatologists actually be able to assess a disease flare from a patient remotely? So these are areas that are still ongoing in terms of um, trying to define and really objectively have a definition of disease activity and therefore a flare in patients with rheumatoid arthritis.
Dr. Rutendo, we want to thank you so much for sharing your expertise with us today, for giving your time to us, and for participation in this podcast where you helped us clearly understand by breaking down the complex topic of rheumatoid arthritis in a very simple and informative way. Thank you so much.
Thank you so much for having me on your podcast. I really appreciate it, and I hope it will be of use and will help us manage our patients better.
Definitely, Dr. Rutendo, and we're looking forward to having you with us for many more future podcasts together.
Definitely.
And to our audience, remember to subscribe to our MedSynapse channel for more informative content like this. And to all the healthcare professionals out there, make sure to register on our MedSynapse platform to stay updated with our latest podcasts and medical information. Your engagement is essential in promoting health and knowledge. Thank you for joining us. Until next time, goodbye.